Representative Ferguson if she has any comments today.
Thank you, Madam Chair. I would like to welcome a new member of our committee. As you all know, Kelly Link, our formidable chairman of the House, resigned, and Representative Jack Fortner is taking his place. You want to stand so we can? We're delighted to have you in the house. I certainly enjoyed having dinner with him the other night. He is a veteran of the Vietnam War, and he is a vintage car guy. And I still have, I'm the original owner of my 1972 Skylark convertible from college. So we had a nice conversation. So we welcome you, and we'll enjoy having you on the committee. Thank you.
All right, ladies and gentlemen, just want to do some little housekeeping notes here. I want to tell you that I think the last time we met, we stayed until about 6:15 in the evening, and I think that's kind of hard on the staff. And so, since we have heard these last two items, some twice, this will be the second time, and another one 3 times, we are going to walk out the door no later than 5 o'clock. And we would ask that you would just be concise in your questions, and we're asking that the agencies, when giving an answer, would be concise as well. First of all, I feel like that today the meeting is really giving a chance for everyone to make comment on the rules after the public comment period ended on November 13th. And we're having this meeting, which is unusual that we would hear these things again, but it was to give those who felt like they weren't at the table or felt like that they hadn't had all their questions answered a chance to do that. And we feel like that we have done that, and we feel like we have done it well. And I have asked the agency with Dawn Stewart and Kelly Link and Dr. Green, and I guess Melissa is back there or someone, I'm not sure, all of that team to come to the table. And because of the confusion to some of these issues, not only for the committee, but for those in the room today, that come and just give us an overview of some of the things that we'll be talking about today. And after that, I am going to ask the Bureau of Legislative Research to come forward and tell us about our responsibilities as the Public Health Committee and what that means in terms of rules and regs. So if Kelly and his team would come forward, we would appreciate it. And we'll just let you, when you get settled, just introduce yourself for the record, and we will be excited to hear what you have to say today to lessen the confusion.
Madam Chair, John Cufford over here.
Oh, yes.
Don't you want to approve the minutes first?
Well, I'd like to wait just
Okay.
a minute.
Okay.
Kelly Link, Legislative Intergovernmental Affairs, Department of Human Services.
Can you pull that to your,
Little further?
Yeah.
There we go. Kelly Link, Legislative Intergovernmental Affairs of DHS.
Dawn Staley, DHS Deputy Director and Medicaid Director for DHS.
Paula Stone, Assistant Director, Division of Behavioral Health Services.
Charlie Green, I'm the Director of Behavioral Health Services.
Melissa Stone, I'm the Director of the Division of Disability Services.
Madam Chair, would like to go over, as you suggested, what will be talked about today, and if I could first address a little bit of confusion I've heard from several members that have called in the past couple of weeks. We're not going to go into the hybrid model at all, or what that's all about today, because we'd be here literally for days. But what I'm hearing is, you know, why do we need these rules if we're looking at a model of care, whether it's a hybrid model or whether it's managed care or whatever it is? Why would we be looking at these rules? And this is completely different. These rules of caring for behavioral health and for the development of the disabled need to be in place to provide the best care, whether a company is managing the care, whether we're using a hybrid model, or whether we're doing fee for service. These rules are completely separate than anything that would have to do with managed care and how that care, whatever company might do that. And with that, we might go over what the three rules, I believe Charlie and Paula have two with behavioral health, and Melissa has one with BD.
All right, you're recognized. Just state your name for the record, please, sir.
Charlie Green, Director of Behavioral Health Services. We actually want to speak to the first rule, which is, as we talked about the other day, a very comprehensive overhaul of the mental health system, mental health and substance abuse treatment system in Arkansas. I'm going to ask Paula, who's a clinician and has been doing this for about 3 years now, to give a real brief explanation of what that overhaul entails.
So currently in our system, we serve about 110,000 people through Medicaid for behavioral health services. And when I say behavioral health services, that is those services provided to those with mental illness, disorders like depression, bipolar disorder, schizophrenia, or substance abuse services. So those individuals who have a substance use disorder. In our current system, particularly with Medicaid, we have pretty much two levels of service that we're providing. We're providing outpatient services and we're providing inpatient services. Inpatient services are high-cost services. They should be provided for those that need those services desperately, and they should be fairly short-term, and people always go back into their home. We don't raise children in institutional settings, and we don't have adults that can go live in institutional settings. We also believe for behavioral health that people can recover. That's the end goal for any services provided with behavioral health. We want those people to recover, and recovery means that their symptoms of mental illness or substance abuse disorder are managed, and they can be managed in a community setting, and those individuals become productive members of society. If they're adults, they have jobs. If they're children, they're successful in their school setting and are living in their home setting with their family or caregiver. So with those two services, those outpatient services and those inpatient services, what we've looked at with other states and what's shown to work is that we provide more intensive home and community-based service. So our proposal really rounds out that. And so instead of this and this, we have a bit of a rounding of that. We're in the middle for those people that might go into an institutional setting, that they get intensive home and community-based services that are targeted. So what we know is the only thing that saves money in mental health or behavioral health is providing services that are easily accessible, that are high quality, that they're targeted to the specific population, and that they're provided in a home and community-based setting. So we want to have 3 tiers of service. One is a counseling level of service, and we want that counseling level of service to be easily accessible to those who have a mental health or behavioral health disorder and need those services. Those services can be provided by master's level clinicians in the community setting. And those people can receive those services, medication management. If they need additional services because they have more intensive needs, and that's something that happens a lot in behavioral health, then those individuals would get more intensive home and community-based service, a broader service array. And the broader service array that we're talking about for children and youth would be something like behavioral assistance to support that child in their community setting, in their school, home and community-based services for the family or the teacher to really help them learn how to manage those behaviors and how to support that child in being successful. We have services for transition age youth to help them learn to be independent and learn to manage themselves and manage their situations so they can go on and work and learn life skills. And for adults that suffer from those issues, we have a couple of different things, but we have definitely life skills development. We have supported housing and supported employment, so those individuals are supported and integrating in the community. And then for the last tier, tier 3, for those individuals that are a danger to themselves or others and cannot be maintained in a community setting, for those with the most intensive needs. And that typically is your highest, like 1% of the total population, 1 to 3. You would have services that we've built on the adult side that are called therapeutic communities, where they really have some monitoring and support. And again, for children and youth, there are some children and youth that just cannot be maintained in the community for their own safety and for the safety of the community, and they can receive those intensive services in a institution institutions, either a residential treatment center or residential treatment unit. Always, with all the services, particularly for those with more intensive needs, we're gonna have care coordination. This is gonna help transition those individuals, because what we're always looking at is transitioning those individuals into the lowest level of care to receive the least amount of services that they need to support them.
Thank you, Paula. Kelly said it best the other day, that while people are very interested in the amount of savings that this overhaul might produce, more importantly, it's the best thing for children in Arkansas. It's best practice. It's the best thing for adults with mental health and substance abuse issues. We've been wanting to do it a long time. I do need to address an issue that was a subject of quite a bit of discussion last time, was the fiscal impact of this. And we had brought over half of one, and we shouldn't have. We should have made sure we had the whole thing done before we came to public health, and I apologize for that. But we have done that analysis now. We feel like that we'll save about $83 million. The infrastructure costs associated with this are gonna be somewhere around $7 million. That'll go for a system administrator to help us with those the counseling level of service, which is a huge number of people, probably 80,000. And the independent assessment, which is gonna be somewhere between $2.5 and $3 million, depending on how the RFP comes out. So we feel like we'll net somewhere in the neighborhood of about 77 million. And with that, and I know we wanted to go over everybody's and then take questions. I'll turn it over to Melissa.
Thank you. So I'm here today on the last proposed rule on your agenda. DDS is asking to move forward on implementing a threshold for OT, PT, and speech therapy for children who are developmentally delayed. This would affect CHMS clinics, CDTCS clinics, standalone therapy, and school-based. We have a number of therapists behind me who have been in support and actually brought the proposal to DDS, and have been working with the department to get this regulation passed. We have some opposition in terms of some standalone therapists who did not feel included initially. We have spent an enormous amount of time in trying to make them feel included from the point we realized they didn't feel that way. So we've attended a number of meetings, posted it on our website, promoted it on Facebook, sent out mass emails with thousands of people, and feel like we have done some outreach, especially in the last, I would say, 3 weeks, to this particular group so that they would feel heard. Just because they feel heard does not mean they agree, and we get that, but we are wanting to move forward today. We are not changing the medical necessity criteria. We are implementing some thresholds for quality control measures. We estimate that this will save the state $16 million annually with an $80 million price tag over 5 years. We believe this is best practice. It is not a deterrent or a stop for therapy. It is merely a threshold. 90 minutes of speech, 90 minutes of physical therapy, and 90 minutes of occupational, if prescribed, will be allowed, no questions asked. These are for those evaluations who are currently prescribing large amounts of therapy for children. Having someone take a second look. We have made a public commitment to use pediatric clinicians, pediatric OT, pediatric speech, pediatric physical therapists to do the document review. And we've also made a commitment to do a 72-hour turnaround, so there's no disruption of any services to these children. So we ask today that the rule be passed.
I'm sure that's the 3 rules that the Department of Human Services would like to present to you, and we can go into whatever detail whenever you're ready.
All right, let me ask you, would you stand for questions?
Anytime, yes,
All
ma'am.
right, Senator Flowers, you're recognized for a question.
If I'm hearing you all right, both Paula and Melissa. You're talking about children here. And I'm not sure under Melissa's, with the developmental disabled children, we talking about children that are subject to IEPs?
Yes, we are. I had a meeting with the Department of Special Education, and I actually was able to talk to the board of directors of the special education directors this morning.
Okay, I'm concerned about this. My understanding of the Individuals with Disability Education Act, there is a team of individuals who have some concern about that child. It includes the parents, it includes individuals that the parents want to have present. It can include providers for that child, evaluators, and the team makes a decision. So I'm trying to understand how does this rule conform to the Individuals with Disability Education Act? Now that's federal law. So I don't see how we can just run around that federal law.
So we're not trying to get around the federal law by any means. If the IEP meets and they decide a child needs greater than 90 minutes of therapy, that evaluation will be turned in and it'll go through the PA process. Now, when I met with the special education directors this morning, they understand that they continue to provide the difference in therapy even if we deny it. We've also made a commitment to work with them on the prior authorization process. They are fully in support of moving forward with these thresholds. They are seeing time and time again kids not getting school at therapy and actually being checked out of school and taken to an outside clinic that's both disruptive to their classrooms and kids are getting behind. If you look at the numbers that we're talking about, we're only, the spend in school-based therapy is about $400,000 and the spend in standalone clinics is $10 million.
Well, I'm not so much concerned about the spend amount. It's about the children that have been diagnosed with these disabilities that I'm concerned about and have been prescribed by their medical providers as well as a team that meets pursuant to federal law to determine what the best course of treatment is for a child. And so if you say that they can still prescribe it, have it as a part of the plan of that child, but yet Medicaid does not pay for it, then how is that providing a free, appropriate public education for the child?
So what's currently happening right now is the feedback we're getting from the schools is that even if they're doing the therapy and the child is getting therapy at school, many times the child is also going outside of school to get more therapy from independent clinics. And it's almost a race to the billing. So school districts are eating the cost at this point when they're not allowed to bill Medicaid because another outside clinic has already billed. We're doing 2 evaluations. We're doing an evaluation at the school with the IEP team, which is promoting in-school therapy. They're also getting an evaluation with outside clinics. So we have several problems going on with the school, and that's why they're in promotion of this, thinking that this will help what's currently going on.
Well, my experience has been that a lot of the schools in Arkansas don't understand the rules, don't understand how to implement the IDEA. And so for someone at a school that suggested that to you, I would disagree with them. And I have another question right now, Madam Chair, if I can.
I have about 4 people on the queue here, but go one more.
At the last meeting, I thought I understood you all to say that these rules had to be approved by the feds. Is that right?
Yeah, the changes to OT, PT, and speech will be approved, will be submitted for approval at CMS.
Okay, so they won't immediately go into effect?
No, ma'am, they're not set to go, we have an implementation schedule of July 1 of 17.
Okay, so what you're doing is creating this rule, wanting to get it passed so that you can submit it to the feds? And it would go just to CMS, or would it go to the Department of Education?
It would go to just the CMS, because it's going to be part of the state plan.
Well, okay. Thank you, Madam Chair, but that is the problem that I see with this. You know, you're trying to put things in little boxes, and it's inappropriate for it to be in one little box. When you're talking about children and education, and there are specific laws that deal with these children getting a free, appropriate public education. And I don't know, in our experience that I have seen in Arkansas with the private option, going on 2 different tracks and getting lost here with the insurance part and then with the Medicaid part. But I would question whether we're not gonna have some problems in the future with this.
All right, thank you so much, Senator Flowers.
Senator Bledsoe, if I might,
Yes, please.
Courtney Salas Ford, I hate to put her on the spot, but she has come here to support me on this role, and she is the attorney for the special education
All
department.
right, would she come forward, please, and we would listen to her testimony on that. We're going to have a seat here for her. All right, thank you. If you would state your name for the record, please, you'll be recognized.
Thank you, Melissa. Courtney Salas Ford, Deputy General Counsel for the Department of Education. And I am here to back up and support everything Melissa has stated. They've been great about working with us at the department, meeting with school districts to assuage their concerns. The things that she said in terms of children being pulled out of school for therapy and missing their education is happening. The race for billing between schools and private providers is happening. The school districts are aware of their obligation under IDEA, Senator Flowers, to provide those services, provide the services that the IEP team determines appropriate. And if they're not eligible to bill Medicaid, the district knows they are responsible for those costs. Currently, parents have the right under federal law to deny school districts the right to bill Medicaid. And so they're already eating those costs for many of those children. They provide the services regardless of if they can bill or not. They are hoping that by putting these, I don't want to say caps, but putting that threshold in, that it will assuage and help discourage parents from going outside to get additional private therapy when the school can provide it. The school can provide everything that student needs as part of their free appropriate public education. Their hope is that parents will continue to allow the districts to bill, and perhaps more parents will allow the districts to bill because they see that they're doing what is best for their child. They don't need to go get extra outside. And again, we've talked with Melissa about working together to put in place parameters that would actually benefit the children and benefit the school districts. So all of the school districts that we have received comments from, while they may have at first had concerns about this, once we've explained it to them, explained the intent of it, they do support it. And we did both meet with the AASEA Board of Directors, the Special Education Directors Agency this morning, and they are in support of it.
All right, thank you so very much for your testimony. Representative Wardlaw, you are recognized.
Thank you, Madam Chair. Ms. Dawn, you and I have had quite a bit of conversation about this rule change on therapy. Can you tell me, has the criteria changed for therapy in this rule at all?
No.
And how long would the PA process take? How long do you foresee it to take if somebody was to file for a PA for more minutes than 90?
So we've made a commitment that it will take no longer than 72 hours.
Okay, so that's in your rule, is 72 hours? Is it
No,
written?
sir, but I've made that commitment in front of the legislature, and I made it in writing to the public, and I'm gonna stand by it. We're contracting, and that'll be one of the contract terms.
Okay, and last month's meeting, Madam Chair, can I have one more?
Yes, one more.
Last month's meeting, we legislators received all these emails with petitions tied to them. In these petitions, or in a lot of those petitions, it had a group of companies listed that were supposedly included in this work group. Can you explain to me who was included in the work group and if these companies even existed or not?
Yes, and I think the members of the work group are actually here behind me as well. They can stand up if they would like. But some of the, no one's standing?
No. It's not gonna happen.
You got so quiet. So there was some petitions that went around that were very confusing that people believed were generated from DHS. Oh, there's the work group.
All right, if you are a member of the work group, please stand. Maybe we should do that. All right. Thank you very much.
We're not all here, so there's
Okay.
a lot of us.
There was a particular petition that went around that caused some concern. They had a number of providers listed that were actually fictitious providers. And next to those names was listed UAMS, which was completely false. And so I have on a case-by-case basis sent out the actual list of who is on the work group. But there still is some untruth floating around that's being spread that has fictitious providers listed as part of the work group.
Thank you.
Yes.
Madam Chair. So UAMS was a part of the work group or not part of the work group at all?
No.
They were not at all. Okay, thank you.
All right, thank you. Next on the list is Representative Sullivan.
Thank you, Madam Chair. So I appreciate the clarification that medical necessity has not changed. And I think I heard you say that the new review group is made up of therapists within the area, within the PT review group for over 90 minutes is made up of PTs. You know, that would seem to address the special ed question. That would seem that there's a much higher quality than currently nurses are reviewing that may or may not be familiar with the specific therapy and the specific needs. It seems that this is actually raising the bar, the standard for how high of quality we have in that review, which would seem to make the special ed requirements even better. We're going to be more efficient at meeting that criteria. So if you could say yes or no, I appreciate that.
I agree with you.
Thank you very much. Thank you, Madam
All
Chair.
right, thank you. All right, next on the list is Representative Meeks.
Thank you, Madam Chair. My question is simply this: one of my heart desires is our foster care system and everything, and I have gotten quite a bit of feedback from our foster parents and some concerns that they have. So, could you just kind of go over that? Are they going to be looked at any differently as far as the kind of treatment that they need because of some of the circumstances and life situations that they've actually been in, to make sure that they get all of the therapy that they actually need?
Are we talking about mental health or?
Well, I mean, even
or
all of them, because again, a lot of them will come in and they'll be delayed. I know my own children that we ended up adopting needed both OT and PT both. And so, again, I just want to make sure that because of their unique situation, life experiences that they have to go through, that is not going to be overlooked whenever you're looking at the time needed for them, for the therapy that they actually need.
So for OT, PT, and speech, so as you know, Representative, I came from the foster care world before I came over to DDS. So foster kids are very dear to my heart. And they do, due to environmental neglect, a lot of times, for example, not being picked up, just basic neglect, are delayed. And so we need to take that into consideration. We're currently writing the specs for the prior authorization process, and we're welcoming any kind of feedback such as that, of special things that need to be looked at when these clinicians are looking at the documentation.
Well, again, I would obviously have them actually take a look at the unique situation, again, that a lot of our foster kids are in whenever they look at the time needed for the actual different therapy. So I would actually, you would take that into consideration.
Oh, well.
Thank you, Madam Chair.
All right, thank you. Senator Irvin, you're recognized for a question.
Thank you. So I think you've answered a lot of my questions, but just to get clarification, you did fix your financials on F, that rule, correct? So you made changes to that fiscal information on item F. Is that correct?
Yes.
Excuse me just a minute. members of the committee, we are going to individually hear these items, so if you would rather
I
wait.
thought we already did.
No, well, we've heard them, but we're gonna hear them again. This is just a preliminary to what we're doing on D, E, and F. Because your question was about F, was it not?
Well, it's also in response to the testimony that they just gave,
All right,
which was the
Yeah.
fiscal impact update changes you made reference to.
but what about this? Maybe do just an overview, and when we get back to F, we'll go into great details. Could you do that?
Yes, so yes, our fiscal impact has changed. And I'm here today to discuss why it's changed and to go into some detail about that
Okay,
at the proper time.
okay, I'll reserve my questions for that time, thank you.
All right, Representative Hammer, you're recognized for a question.
Thank you, Madam Chair. On the matter that Representative Wardlaw brought up, is a therapist license in jeopardy if there's fraudulent activity associated with the actions of that individual therapist?
So I have a bunch of therapists behind me, but they're bound by ethical duties just like any licensed clinician.
I'd just like to ask you publicly that based on what Representative Wardlaw asked, and I don't know if you want to turn this over to, if it's your division or whose, but if there's been fraudulent statements sent out by therapists that have altered or tried to influence the decision of this body, that they be held accountable, because in all three of those disciplines, trust is a high level, and if that trust has been violated to us, I just wish you do due diligence and follow up on it. And then the next, one other one, Madam Chair.
All right, you don't want to wait and let her answer that one?
Oh, I thought you did, but go ahead.
Wait just a second. Representative Ferguson has something she'd like to say.
I might just comment on that because I have had some concerns about different boards. Maybe members realize this or they don't, but I know particularly about the medical board, they have to have a complaint to investigate something or to call someone before the board, and I think that's probably true of all boards. It's not like just, yeah, we know about it and I'm talking about it. They have to have a written complaint from someone to call that person in.
I'll take care
Thank you.
of getting that to you.
All right, you're recognized.
Thank you, Madam Chair. Is it the official position of the working group that they are okay with all three of these rules that are before us?
So, Dr. Green and Paula Stone have actually been working with a different work group. So I would say for the individuals who stood up just a moment ago, they are here to promote passage of F.
Thank you, Madam Chair.
All right, thank you. Representative Branscombe, you're recognized for a question.
Thank you, Madam Chair. When you made reference to fraudulent companies, that kind of intrigued me. So we were getting information on our emails, sitting out by a fraudulent company. Can you give me an example of that?
I was actually trying to find it.
Because I get them all the time when I'm winning all this money and stuff, and I would hate to think that was the case here.
So, a petition went out that was not designed by the department or the governor's office. And we get a lot of emails like that say, why did you put this out? Why did the governor's office put this out? So we do a lot of emailing back saying, this is not our document. My name's just on it because they want people to contact me and tell me they don't like it. So there was particular petitions that were sent around, like a form letter that went to hundreds of people, and they signed it and faxed it into you guys and emailed it to y'all, that had a list of what they said was the representatives of this provider work group. And on this particular petition that Representative Hammer and Representative Wardlaw are talking about, there was names of providers, specifically one maybe called Kids Spot or Kids Corp for UAMS. And so I received a series of emails that said, what is this company? What are these companies? And so I simply would write back and say, this is not accurate information. These are the people that are on the work group. So there was a series of petitions that people signed with inaccurate members and fictitious companies listed.
Is that prevalent problem? Has it happened more than what we would think it would? Or maybe you do think it does. Does it happen quite a bit?
Well, this has been unusual. We've received so many comments back on this particular rule. It's been a little unusual from the ones I've dealt with in the past. But it is common to get bad information out, especially in today's world with Facebook and social media, and it just spreads like wildfire, and it's hard to rein it back in and correct it.
But this is the first time that I'm really aware that we've had companies represented that didn't exist to put out information. All right.
I think the company that actually put out the information does exist. The people they listed did not.
Okay, all right, thank you.
All right, thank you. Ladies and gentlemen, seeing no other questions, we will excuse you, but don't leave, because we'll probably have you come back. Believe it or not, those of you in the committee, we have not started our meeting yet. This was just a preliminary to help with the confusion as we saw it, and we thank you very much. We have a wonderful team here for VHS, and we appreciate your patience with us and your kindness to come and help us. All right, proceeding to try to kind of plow through the fog, I have asked the Bureau of Legislative Research to come and talk to us about the responsibility of the Public Health Committee and also as it relates to rules and regs. And if you would state your name for the record, we would recognize you.
Hi, my name is Jessica Sutton. I'm the administrator of the Rules Review Section. I'm here today to answer what questions you guys may have with respect to this process. The Public Health Committee's responsibility under the law is that of a review process, and it's limited to reviews pursuant to the law. Approval authority over rules rests solely with the Administrative Rules Subcommittee under Legislative Council. So no matter what happens today, this rule will also go before Administrative Rules, and there at that meeting, a determination will be made as to whether or not the rule will be approved or not. As far as your authority to review, you may decide to have the rule considered to be reviewed. You can have the rule considered not to be reviewed. Obviously, if you have it reviewed, that would somehow signify that there's some favorable ruling of this committee, and we would look at that. If you decided for it not to be reviewed, then we would see that you were not in favor of the rule.
All right, let me ask you this, because I want everyone to hear this. The responsibility of the Public Health Committee is just for review.
That is correct.
Right, and if, no matter what happens here today, rules and regs will hear this issue.
Yes.
All right, that's what I want to know. Any questions from the committee? Oh, it's already gone out because we're not going to have time to answer any of the questions. We're going to receive the comments. So, oh, I'm so sorry. No, I just said that. I said, what did all those in favor say? It's going out, it's not reviewed. All right. All right. You are, I believe you're dismissed. Go ahead.
Madam Chair, I think we're here for F as well.
Pardon me?
If you'd like us to leave.
Oh, okay, no, I didn't realize that. No. Is anyone else coming to join you? You look lonely.
I feel lonely.
All
I
right,
think
here we
Director
go.
Stone is joining us.
All right, item F. All right, you're recognized. Oh, state your name again, please.
Senator Melissa
All right.
Stone, Director of Developmental Disability Services. So I think we went over kind of what this rule does, but I would like to clarify on the fiscal impact statement, because what was presented previously, similar to behavioral health, was not correct. So, and I apologize for that bad information. Other codes were kind of I'm not a data person, but other codes were entered into the analysis that spit out that $56 million. That should not have been in that analysis. When you look at what codes this is affecting, I went through them earlier, DDTCS, CHMS, school-based therapy, and standalone therapy. When we ran the data analysis on those particular services, we come up with an estimated savings of $16,281,000. So that's the number that was presented, I think, on the updated fiscal impact statement that talks about what we project the savings to be. And I did go back and look at a current Beacon contract, just as a reference for how much a PA process would cost. And I just did some scribbling over here. They, on that particular contract, they review PAs as part of the contract. So for a PA review, I think we pay them $23. The number of kids, the maximum number of kids that this proposed rule change would have on therapy thresholds is 23,000. So that's the maximum number of PAs we could receive. And if you multiply that times what we currently pay Beacon, we're looking at a contract around $553,000. Now, of course, there would have to be probably some administrative fees included in that, so it might be a little higher. So we feel like we will get really close to our savings projections because the contract will not be very expensive.
Thank you. That answers my question I had at the beginning of the meeting. Thank you very much.
Okay, seeing no further questions, we'll see Ms. Rules and Regs as reviewed. Thank you.
Thank you.
Okay, sorry, there were some people that wanted to speak against it. Do they still want to come to the table and speak? Oh gosh, there's a. Yes. Yeah, I heard you. We're gonna come back. Yeah, we're gonna come back to whether it's reviewed or not. I didn't realize we had people signed up to speak against it. I'm sorry. Scott Harmon, Marilyn Booker, Julie Dickerson, Priscilla Faulkner, Lainey Morrow. Yeah, is that all? That's all I have on the sheet. Is there anybody else signed up to speak for it? Okay, I think we should hear the speaking against first, since DHS just spoke. Who is here to speak against? Okay, you want to introduce yourself?
My name is Scott Harmon, and I'm an independent provider. I have 2 outpatient therapy clinics in Faulkner County. We provide OT, PT, and speech. I've also been asked by the Arkansas Occupational Therapy Organization president to represent on the work group for therapy advising work group. I'm asking that this proposal be held at least as not reviewed. Representation on the work group by independent providers was only brought on after the train left the station. The proposal had been set, the therapy thresholds had been set, and then we were allowed to come on. So we were not fairly represented on this work group. I also submit that the savings on the therapy will not be as great as proposed. The work group is comprised of developmental preschools. Those developmental preschools, once that threshold is implemented to 9 minutes, will fill in the gaps with more clients. So the proposed savings will not be as great as is submitted. I've not seen any solid numbers. We've seen some numbers of savings, but we don't know where those numbers are coming from. I think there was an FOI on that, is what Stephanie said, and but those are not real solid. The other thing I would propose is that precedent is in motion to favor these developmental preschools, which would really burden those who provide therapy in a rural setting, have a rural therapy clinic. And so once that precedent is in place, if parents have a difficult time getting to therapy because they only can go to these big centers, I would suggest that that's an undue burden on a poor population. I would also submit that I've not seen what all has been proposed in order to save the money. Was only a threshold of therapy submitted, or was it submitted to save money in other ways? We don't know. We haven't seen that.
I have a question.
Sure.
I know part of the reason that I asked this to be held over from the October meeting was because the independent people had expressed concern that they had not been heard. Have you not had an opportunity to meet with DHS in the interim between the last meeting and this one?
Well, yes, but as I mentioned, the train's already left the station. The proposal's in place. It cannot be turned around. That's what we were invited on. And there might be some other independent practice owners here who agree with me. There's a group of us who have banded together, and we might have sent out some emails to let our representatives know. But that's my proposal, is that we were brought on too late. It was a done deal.
But they did meet with you then. Okay,
Yeah.
thank you.
That's all I have.
Oh, who wanted to go first and speak for? Okay, but introduce yourself. Bring the microphone to you.
Marilyn Booker, pediatric physical therapist, and I'm here really just to share information. I'm with the Academy of Pediatric Physical Therapists. I'm the Arkansas State representative. And I think I just wanted to share with the committee that I was hearing a lot of discussion about school-based therapy versus outpatient therapy. School-based therapy is supposed to be educational and relevant for children, so the guidelines and the criteria and the amount of service time would be quite different than a medical base. And most of the children that we see, I've worked in multiple settings. I've worked in schools, centers. I've been in the state of Arkansas for 25 years, seeing children in a variety of settings. Most of the children we see have needs through their lifespan based on their diagnosis, which will have varying needs and oftentimes are above and beyond what's in the school system. I know a lot of clinics that serve children that provide evening service and weekends so that they will not be pulled out of the school. So I wanted to share that information with the committee. And then I just had some questions because I know I went to a meeting on Tuesday and I heard that there wasn't data available yet. So I just had some questions about where the data came from about the cost savings and if where that would be available to look at. And then also if anybody looked at different threshold levels to kind of determine what the cost savings difference would be with different threshold levels. And my last question would be, do we anticipate, if indeed there is a threshold level, that the PA process would be in place when that became effective? So that those children that really need the services above and beyond whatever threshold may be determined can have that service and don't have an interruption in that service, which would impact their life. Thank you.
All right, you're recognized. I'm Lainey Morrow. I'm a parent of a child who would be affected by this proposal. And from what I'm gathering, there is pressure here to pass this because managed care is a threat. I feel that threat as a parent. I've lived in a state with managed care, and my child did not receive treatment. She has all of the documentation to prove that she needs that treatment. She receives that treatment in this state, yet she did not receive it under managed care. And I would submit that that is now costing you all money because of the bad decision that another state made. So please don't go there. I would like to say that as a parent, I've been included in the work group. Melissa Stone has met with me. I'm sorry that people were not included previously to this, but they have presented data at this, specifically the last large work group meeting, that shows thresholds for age groups and how much money would be saved for each one of those. So, I mean, if it's managed care or this proposal, my child will, I've been at face value, this proposal says my child will receive treatment. The documentation can prove she needs it. And so I would ask you to review this and pass this on to the next level so that we don't get to a situation where it doesn't matter what providers think or what children need because they're not going to get the care they need. Thank you.
All right, thank you very much. Let's see, Representative Payton, you have a question and you're recognized.
Thank you, Madam Chair. My question is for the gentleman at the end. You said you're a provider, and so I think you mentioned you had 2 different clinics. Can you give us an idea of what percentage of your patients would exceed the threshold that's being set, and how difficult that would be for you to call and get the prior approval for extra hours?
We don't know the rules yet for PA as far as what it's gonna take to get that extra time. I looked at the numbers, it's been a few weeks, so, it's around 35% of my clients who exceed that 90-minute threshold. Those who exceed that 90-minute threshold are pretty much all 120 minutes, and so those were basically 2 times a week for an hour session each.
Okay, so currently roughly a third of your clientele are exceeding the threshold, and the other 2/3 are not.
Correct, but I'd have to look at the numbers again, but I imagine it's pretty standard for every facility that those who exceed the 90 minutes are probably 0 to 5-year-old.
My next question is, of those that are exceeding the threshold currently, would you expect to attempt to obtain authorization for the extra hours on all of those, or would there be some of those that just wouldn't be worth trying to get the extra hours for?
There again, we don't know the rules. I would have to see the rules to definitively make that statement. So, that being said.
Well, the rules may prohibit, but I'm asking whether or not you would attempt to get those extra hours.
If it warranted it, yes. I mean, if we were within the rules of the PA, sure.
I'm just trying to see where the savings comes from. If all of them are getting extra hours, get the hours they need afterwards.
Yeah.
Okay, thank you. Thank you, Madam Chair.
All right, thank you.
Yes,
Yes, please.
there are members of the work group who have data that speaks to that specific question. And from what I understand, everyone who needs it will get services. The PA process is being written now. The work group is including any provider who would like to be involved. So I would submit, please go talk to them. They're here today.
All right, thank you. The lady in the middle here, I don't think you've had a chance. Would you identify yourself for the record?
My name is Priscilla Faulkner. I'm at LPC. I believe I had written down letter D on there for the behavioral or the peer system. So I don't know. I would just like to have something to say about that. So I don't know if we need to wrap this up.
Go right ahead.
Okay. Basically, I'm here in support of my clients. I work for a provider, a contract with a provider I'm very pleased with, but my concern mainly is that the changes that potentially could occur, how is this going to affect the treatment that they receive? About 90% of the clients I work with do have PTSD. I do work like in a group home facility where DHS has stepped in and placed these kiddos. I also work in school base. So I'm undecided at this time because I really don't have enough information to either be for this or against it. I do believe I have several of my LPCs that I work with in the back who are right there with us. We just would like some more information. We're here to make the best informed decision for our clients. There are some concerns that I do have as far as a 50-mile radius. I do live in Derrick, Arkansas, and so there are a limited amount of providers in that area as far as professional counselors. And then with the 50-mile radius, a lot of the providers are in Texarkana, Arkadelphia, and so many of these kids are falling in the outlying areas and not receiving treatment. I do feel like he needs to be made aware of that. The second point that I would like to make is that I am concerned about the independent assessment. I'm not really sure what that entails, but I do know that when I receive a referral from a PCP or the school, I can at this time make an informed decision and give a diagnosis to my client based on the symptoms in the DSM-5, and then determine along with the doctor who works for us the course of treatment. So those are just some statements that I have, and I would welcome any kind of questions as far as what services we provide in a school-based as well as group home.
All right, thank you. Are there any other questions? questions? Yes. All right, Representative Hammer, you are recognized for a question.
Thank you, Madam Chair. To the gentleman on the end, tagging on what Representative Payton was asking, of the 2/3 that are below, do you know approximately where they fall as far as underutilizing the 120 hours that are available to them?
My clients are not being underutilized. I don't understand the question.
Well, if you can, and maybe I'm misunderstanding, that's why I want clarification, if you can, utilize up to 120 hours, and you said 2/3, if I understood it, don't get to that, what percentage, or give us a number, like they're using 70 hours, 80 hours of that block of 2/3, what would you say or estimate based on your personal experience?
Okay, so it's 120 minutes per week.
120 minutes.
The threshold proposed is 90 minutes per week. So I'm not sure I still understand the question that you're asking.
Do the majority of the 2/3, are they coming in at 60 minutes a week currently, or what that block of
Oh, okay,
2/3?
that's what you're saying now. There again, I'm a microcosm of other independent practices. Probably most of them are 90 minutes. We do see some for 60 minutes. We see some for 30 minutes. We see some on a consultative basis where we see them once a month. But a majority of them are probably at 90 minutes.
So in the law of averages, when it comes to what you bill for on the 120 minutes based on your practice, how much of a financial hit do you anticipate taking as a result of what this rule change may bring?
There again, I would have to look at the numbers again. I did look at these numbers. It's been probably a month. As far as the financial hit, maybe revenue around 15%. I have to look at it again. Maybe 20%.
Are any of you four sitting at the table responsible for the emails that we got? Are you part of that fictitious company?
Yes, sir.
Thank you.
Because I'm trying to remember numbers because I work in a large outpatient practice. I believe we see 1,000 children, and I'm sorry, I hope I'm correct in my numbers, but I believe around 60% of our children maybe receive 120 minutes a week. That's precisely in my 25 years of practice. We vary the scale based on what the child needs, but that's not an uncommon amount to see children. So I think in seeing 100,000 children, I believe a revenue issue is around $3 million.
Madam Chair, would you let me speak to the authorization process? Do y'all have a lot of difficulty when you have to ask for reauthorization of additional minutes now, or what's your experience there?
There's not currently an PA. There's not a prior authorization process at this time. There has been an Arkansas cash for right now it's a retrospective review. So you see the child's direct evaluation and recommendation for care, treatment, and then the AMC comes back and there's a retrospective review for medical necessity and appropriate documentation.
All right. Representative Sullivan, then Representative Meeks, and we've got 30 minutes, and I would like, after this is over, I would like to call those who wanted to speak against E. If they want to come to the table and do that, we've already passed it out as not reviewed, but you're welcome to do that. But anyway, we kind of had a mix-up there. But anyway, Representative Sullivan, you're recognized.
Thank you, Madam Chair. We talked about the acuity levels. If you have children that are 200 or 120, whatever those are, do you have any data or response that there may be value, or would you agree that there's value in seeing that a child is currently at, let's say, 190, may be seen at 150 and still have appropriate care, and that there's value in someone making that independent judgment?
I do not have that study in front of me as far as goals met and achieved at 120 minutes per week compared to 90 minutes per week. Somebody in this room might. I don't have that.
But that's what I'm asking you, if you have, because I think that's one of the points that we're making here. There's value if the child is being seen at 180. Can they be seen at 150 and still have the same outcomes? We don't know that now in the state of Arkansas, and I think there's a tremendous amount of value in taking that look at that. Would you agree?
I would agree that's true, and that there, again, if we had more time, we could possibly look at that.
And you just kind of, for your information, I had several constituents call me who have private insurance that are paying for everything they get. And they're very concerned that children in Medicaid services receive much more extensive care than their child gets at the same level. So when I'm sensitive to when people say, my child won't get care, they can get care, you'll just have to pay. And currently, the people on private insurance are paying a lot of money for that. And we as legislators represent them also. So while we are very concerned that all children receive appropriate care, we have to be aware that people on private insurance don't get near the level of care that kids on Medicaid get. Thank you, Madam Chair.
Thank you. Yes.
We would like to speak to that.
Okay.
I am on TEFRA, which means I have private insurance and I have Medicaid. The reason for that is my daughter has a profound delay that private insurance can't even possibly come near covering. So, I mean, we pay for TEFRA, we pay a premium, and we pay for private insurance also. I have debt from the previous state that I lived in trying to cover these things. So I would like to say we're very thankful for the coverage that we get. This is amazing. She didn't get it in another state, and she is delayed because she didn't. So thank you for what she's receiving, but I mean, she needs it. That's why she's getting it.
All right, thank you. Now, I will ask you to be brief. Okay.
It's just a research study that was recently came out in our literature, and it was a meta-analysis of 50+ studies. And it did suggest, and it was looking at what's effective in therapy and what's not effective in therapy. And as a profession, we are working more in that direction so that we can really talk about numbers and how we're seeing gains. But one of the things that was most important was frequency and intensity of service.
All right, thank you. Yes, sir.
My initial argument was not against the 90-minute threshold. That might be what needs to happen. My argument was representation on the work group, and the group that was making that proposal was heavily made up of developmental preschools who have a whole different business model than us independent practice owners. They certainly make their revenue off therapy, but they also make a large chunk of the revenue off preschools. And so they might have different motivations to propose certain actions, and we would just like to know what was proposed, or was that just a single item?
All right, thank you. Representative Meeks.
Thank you, Madam Chair. And Mr. Harmon, this question is for you because you kind of said something that I need, I guess, maybe to get some more clarity on. You had mentioned that, you know, if we were to cut back on this, the developmental preschools, all they would do is they would just go out and get more clients, I guess, to fill in that gap. So what you're telling me now is that there are children out there who need services who are not getting them for some reason, either because of capacity or because of funds. And actually, by making this change, it will be a good thing because more children will now have access to services that they need. So I would ask that maybe you clarify that particular remark, and if developmental preschools are able to do it, why would your company not be able to do the same as to go out and also to now service new clients because you potentially would have that time and more capacity?
I would speculate, and I say speculate, that developmental preschools potentially have a larger waiting list in that the parents are seeking the preschool and the therapy. So that's speculation on my part. We certainly could generate more clients. What we're running into now, and I imagine what most therapy practices are also running into as far as seeing more clients right now, as the system is finding the therapist to see them. Right now, I'm looking for an OT, for a PT, for a speech therapist to see clients who need therapy. So that's my answer as far as certainly more kids could be seen, and that's a good thing. More kids get services. But the money's not going to be saved with a 90-minute threshold because the gaps get filled. That's my point.
All right, thank you, Madam Chair.
Thank you. All right, there are no other questions? Oh, Mr. Payton, here you go.
Thank you, Madam Chair. I would like to follow up if I could. Mr. Harmon, you just spoke exactly to what my concerns are, whether or not we're going to realize any savings. And it appears we're adding a level of management that's gonna cost us money. And it's also going to draw from the field of professionals who are providing the care. Some of those people are going to end up in management, and so we're going to further reduce the availability of care. In your clinics, you know, when you have somebody that you're given 90 minutes a week, does that just stay that way forever, or do you adjust it up and down? And how? Because what I'm thinking is if we have this level of management where you have to get approval for anything over 90 minutes, then you're going to feel locked in and not want to make adjustments to that. So how does that fit with your normal procedures?
Currently, each child has to be evaluated every year. We do have the option of evaluating them sooner than that, of discharging them sooner than that. If we think that child has met all of the goals, has made all the progress that they're going to make, we can certainly discharge them before that. But at a minimum, in our clinic, they have to be evaluated every year. In the school system, they have to be evaluated every 3 years.
So basically, they stay at the same level for a year, at least. You don't really adjust them up or down.
It depends on the child. I mean, we have some children who, for whatever reason, might start out at 120 minutes, into whatever time constraints or scheduling might get bumped down, or they might have some drawback as far as having more difficulty and need more therapy, and we could reevaluate them and request more therapy. So each child is individual in that manner.
Thank you, Madam Chair.
All right, thank you. Are there any other questions? All right. Yes, Representative Fine. All right, this is the proper time.
I make a motion that we send this out as review.
All right, thank you. That's a proper motion. All those in favor say aye.
Aye.
All right, thank you very much, and thank you. Okay, I'm sorry. You're right. I got real excited there. All right, all those opposed? All right, thank you very much.